Bonjour, chers collègues, et
Good morning, dear colleagues. Welcome.
Hello. Hello, colleagues. Welcome to the 19th meeting of the
January 3rd.
As always,
As usual, interpretation services are available with the globe at the bottom of your screen. Please follow the directives from the Bureau with regarding the wearing of masks and other protocols.
To remind all participants that screenshots and taking photos of your screens is not permitted. Et avant de prendre la parole, s'il vous plaît, attendez que je vous nomme.
Before speaking, please wait until I recognize you by name. When speaking, please speak slowly and clearly. When you are not speaking, your mic should be on mute.
Je vous rappelle
A reminder that all comments by members and witnesses should be addressed through the chair.
colleagues, I would now like to Buenos días, Vice-Ministre.
Vice Minister, welcome to the committee. You will have 5 minutes for your intervention.
To you, please, for opening remarks.
Muy buenos días, buenas tardes para ustedes.
Good morning, distinguished members of the Standing Committee on Foreign Affairs and International Development of the House of Commons. I'd first like to thank you for this opportunity to speak on behalf of my country in talking about the tremendous injustice that less developed countries have suffered when it comes to the distribution of vaccines. Thank you for your understanding in rescheduling this appearance following the death of my father. In the first stage of the COVID-19 pandemic, vaccines were not available to all. The beneficiaries were the countries with the greatest purchasing power, leaving the less developed countries without the possibility of having the vaccines that would protect people's lives. Vaccine coverage in the face of global interests meant that vaccines became a market good as if it were any good, and so it limited what should have been a public good. There are people of first and second class, it seems, some people who don't have a right to health, a right to vaccines. The COVAX mechanism was created with the intention of helping with equitable distribution, but we know that COVAX results haven't been what was hoped for. And still today, 20% of the global population hasn't been reached, which was the goal at the beginning of last year. The developed world began distributing vaccines through COVAX when they were about to expire. So vaccines that wouldn't last much longer, and developing countries like ours, with many people in rural areas that are difficult to access. Bolivia trusted in the multilateral plan for global crises and proposed using the flexibility of compulsory licenses contemplated in Articles 31 and 31 bis of the Agreement on Trade-Related Aspects of Intellectual Property Rights, TRIPS. To this end, Bolivia has worked with Knowledge Ecology International Key, an organization dedicated to access to medicines and vaccines with offices in Washington, D.C. and Geneva. Key collaborates with the Canadian company BioLize Pharma, which has a capacity to manufacture approximately 20 million COVID-19 vaccines per year. So this Canadian company could have immunized 20 million people in the world if the compulsory licenses had been granted. Bolivia signed an agreement with this company in May 2021. So they could manufacture and import 15 million Johnson & Johnson single-dose vaccines, and this was subject to obtaining a compulsory license, which is required to respect TRIPS. So a year later, many people in Bolivia have died from COVID because they haven't had vaccines in a timely fashion, even though the production capacity was there. Bolivia initiated the compulsory license process by notifying its use as an importing country and has requested Canada, in accordance with its legislation, to notify its intention to be an exporting country. That was necessary, and Canada needed to indicate this at the WTO. So Biolese Pharma is based in Canada, so it had to be produced in Canada. For this contract to work and for Bolivia to obtain the 15 million doses it needed at the time, the political will of Canada was necessary for this compulsory license to be effective. During November and December 2021, the Bolivian position has been heard through virtual press conferences and was supported by the Canadian population with 4,500 signatures that have made it possible to formalize a petition before the Canadian government's House of Commons. The petition was submitted on December 15, 2021 by Member of Parliament Nikki Ashton of the New Democratic Party. The Canadian government's official response noted that Canada is a member of the COVAX mechanism to support countries with difficult access to vaccines. And with respect to the WTO agreement on trade-related aspects of intellectual property rights, so the Canadian government indicated that it will continue to work closely with all WTO members in seeking a consensus-based multilateral outcome to address any intellectual property challenges related to COVID-19. I want to say clearly that Bolivia is respectful of the response of the Government of Canada. However, Bolivia's request was not to receive vaccines through the COVAX mechanism. Bolivia is already part of COVAX and has received a few vaccines through that mechanism, but we could not wait for the consensus of the WTO member countries to change multilateral norms. Bolivia's request was clear and direct with Canada. It only required their political will to grant the compulsory license to Biolese Pharma. Bolivia already had a contract with it for 15 million vaccine doses, and Bolivia could then have access to the vaccines. This was when there were no vaccines and Bolivians were dying of COVID. So the granting of this compulsory license would have been proof that the discourse on vaccine equity is accompanied by actions. It could have left an important lesson to international companies that only look after their own economic interests more than public health and people's lives, and to the powerful countries that stockpiled vaccines in the most critical stage of the pandemic, sometimes even letting them expire, leaving the rest of humanity to their fate. And this weakens the COVAX mechanism and the spirit of the mechanism due to the lack of availability of vaccines. Mr. Chair, I want to thank you for having granted this time and space. By way of reflection, what remains for me to say is that the COVID-19 pandemic has changed the life of humanity. We've had social, sanitary, economic crises, and unfortunately, bureaucracy and economic interest of some international companies have not changed. The economic interest, profit, has won out over human life. Bolivia had the hope that this path of the use of compulsory licenses would mark an alternative to accelerate global vaccination and defeat the COVID-19 pandemic together. It has been shown that the multilateral mechanism, when it comes to intellectual property rights, doesn't work and doesn't provide equitable access to the world's population. Thank you very much, Mr. Chair, for this time.
Vice Minister Blanco Ferri, thank you very much for your opening remarks. And on behalf of the entire committee, I would like to reiterate our deepest condolences and thank you for being with us on this important issue at this difficult time. Colleagues, Dr. Houston and Dr. Nickerson submitted their opening remarks at the last session. They are available for questions as we go forward. And with that, I would like to go straight into round one. Colleagues will be familiar with the method of timekeeping at this committee. I'm holding up a 30-second card. When you're within 30 seconds of your questioning or testimony time, just keep an eye on the screen. In that respect, it'll help us to manage the time that we have this morning. Round one consists of 6-minute allocations, and leading us off this morning is Mr. Genuis for 6 minutes. Please go ahead.
Thank you very much, Mr. Chair, and thank you to the witnesses. Doctors Without Borders does incredible work around the world, and it's been my pleasure to engage with you on a broad range of issues. I want to start my questions with Vice Minister Blanco Ferri. Thank you so much for being with us today. I always particularly appreciate when we have at the Foreign Affairs Committee the opportunity to directly engage with leaders and officials from other countries. I thought your comment was interesting about whether we view vaccines as a market good or a public good. It seems to me that we are a bit inconsistent in some ways in how we treat these, because on the one hand, pharmaceutical companies seek the protection in terms of intellectual property that comes with being a market good. But in other respects, we've treated vaccines like a public good. There have been grants that have been given for the development of vaccines, and also vaccine manufacturers have been protected through indemnification clauses. We've heard previously at this committee that COVAX has an indemnification mechanism whereby people who bring forward complaints about vaccine injuries can be compensated through a no-fault fund, but industry does not contribute to that fund. So it seems to me that on some level industry gets the benefits of a market good structure, that is the protection for intellectual property, while also seeking the benefits of a public good structure, that is to be insulated from liability in the event of problems, as well as to receive grants for production. So, Vice Minister, I wonder if you can reflect on that question, and if you agree or not with the description that I've offered. And then also, if you can just share a bit about how, in practice, the indemnification clauses work for your country. My understanding is that countries are expected to sign on to indemnification agreements if they want to get access to particular vaccines, and if they have concerns about the indemnification structure, then they won't be able to access those vaccines. So I wonder if you could comment on that and what the process has been like from your end. Please go ahead.
Go ahead. Thank you very much for the question. Vaccines for treating COVID must be public goods. As we have said, these treatments, however, have become commercial products. And of course, the laboratories gave a priority to countries that could pay, since there was a limited production available, and vaccines should be treated as public goods. Vaccination in Bolivia is free for Bolivians without discrimination. And the multilateral trade system because of the system, the vaccines were not available for less developed countries because of the cost. And when we wanted to purchase vaccines, this was a problem for Bolivia, which has to be able to provide or respond to any request from a citizen regarding a vaccine. And the current system with international companies, we haven't been able to provide these services, and we had to either sign a contract or we could not get any vaccines. So the situation was a difficult one. These vaccines should be considered, or we consider them to be public goods, and the current system prevented us from getting vaccines without entering into a contract with these countries, and some providers spoke of these having a contract, or others spoke of previous agreements. So it was not possible to enter into agreements with those companies. Thanks to COVAX, we received vaccines from Pfizer. And we had to enter into an agreement with the COVAX mechanism, and that was how we got Pfizer. But we could not sign direct bilateral agreements with the suppliers, with the producers, because that would have threatened our constitutional obligations and abilities.
Thank you very much here at 6.5. We'll have to leave it there. I apologize in the interest of time. Mr. Sarai, please, for 6 minutes.
Thank you. And again, my condolences to you, Mr. Ferry, on the loss of your father, and thanks for having you back. My question is for Doctors Without Borders. Maybe Dr. Nicholson can answer this one. In November 2021, a CARE International presentation highlighted the gender gap in COVID-19 vaccination rates in low and middle income countries. I think in 22 of 24 of those countries which it operates, CARE noted women are less likely to be vaccinated and less likely to feel vaccines are safe. What is more, women make up 70% of health workers worldwide and therefore more likely to be in roles that expose them to COVID-19. What are women in low and middle income countries less likely to be vaccinated? Why are they less likely to be vaccinated than men?
Thank you for the question. So unfortunately, I can't speak specifically to the CARE report because it's their data and their analysis. What I can say from what we have seen throughout the COVID pandemic has been very much along these lines, where there has been clearly, a differentiated impact along the lines of gender in many of the places where we work. So, for example, at the start of the pandemic, we saw many health services that became suspended, either because resources were diverted, to COVID-19 response, or, and again, we've seen this throughout the pandemic as well, health staff are either sick or infected or have been exposed to COVID-19. And that's led to the closure of many health facilities, the suspension of health activities, and so on. And so we have seen throughout the pandemic a significant impact on women, women's health, and women's health programming. As far as COVID vaccination goes specifically, specifically. I don't believe that we have data on this from our programs, but I'm happy to look into that and get back to the committee.
Would you know how to remove some of those barriers to remove that hesitancy that women have in those countries? Yeah,
absolutely. So in our programs, I mean, everything that we do is done on the basis of a needs assessment. Right, so we are an impartial organization. We provide medical assistance on the basis of need alone. So a fundamental starting point for any medical intervention that we do is a needs assessment to understand, what a community's health needs are, what their priorities are, and how we can best meet those needs. And so part of doing a needs assessment is, of course, looking at access to healthcare and understanding, what some of the barriers to access are. And so, that can be done in a number of different ways. We go to health facilities, we look at who's standing in line. Is it, is there clearly a gender differential in who's accessing health services? We speak with communities to understand what the particular barriers might be for men, women, boys, girls. You look at a number of different factors. And so targeting programs to meet the needs of different communities and the, often structural barriers that different populations may have is absolutely a key part of what we do. And that's also, it's very nuanced and it's very specific based on different communities, different countries, different populations, and so on. So there's not like a one-size-fits-all model, and it needs to be baked into the process of doing these needs assessments and designing interventions.
Thank you. Mr. Vice Minister Ferry, according to our World in Data project at the University of Oxford, 61% of the Bolivian population has received at least one dose of COVID-19 vaccine. How and from whom did the Bolivian government acquire the COVID-19 vaccine doses they've administered so far?
Muchas gracias por la pregunta. Bueno.
Thank you very much for the questions. We received vaccines from various sources. In January 2021, we started receiving vaccines, and we received vaccines from Russia and China. It was difficult to. We did this through a bilateral agreement with the heads of state concerned, and there was a great deal of political will to facilitate receipt of vaccines by Bolivia for the vulnerable population and the general population. And following that, we received vaccines from countries like Mexico and Argentina, these are also the developing countries, and we received other vaccines as well through the COVAX mechanism. So the bilateral agreements were a major factor in the vaccines we had available. Many of the vaccines we received were provided free of charge. However, their shelf life was very short, and they started to expire by August of 2021. I hope I've answered your question.
Bergeron, s'il vous plaît, pour 6 minutes.
Merci, Monsieur le Président.
Thank you very much. We have to.
Sur la question qui a été posée par Monsieur Sarai.
I'd like to continue with the question asked by Mr. Sarai. The response from Mr. Veris showed that it can happen that among Western countries, sometimes the developing countries are thrown into the arms of Russia and China, and this is a very unfortunate situation, especially since we have no real confirmation of the real efficiency of the Russian and Chinese vaccines. So I have two questions for Mr. Berry. First of all, what, in your opinion, explains that the Canadian access to medicines regime has not worked to allow for the rapid provision of vaccines through BioLease? And secondly, have you had any exchanges with the governments of Canada to enter into bilateral agreements or via COVAX so that Canada could provide any of the supplementary vaccines as talked about to Bolivia?
Muchas gracias.
Thank you very much for the question. We received many vaccines through COVAX, which redistributes vaccines provided. We received direct supplies of vaccines with any countries which offered them. We have not received any vaccines from Canada, either through COVAX or directly bilaterally with or from Canada. And as far as gifts from Mexico or Argentina, that was outside the COVAX mechanism. But within COVAX, we received no vaccines from Canada. Now, however, thanks to the Embassy of Canada and we have excellent relations with Canada, but we have not received any vaccines through COVAX or bilateral agreements.
Yes, thank you. We still just don't understand what went wrong.
We still don't understand exactly what
went wrong with the Canadian access to medicines regime, but we'll certainly have the opportunity to dig deeper into that later. I'd like to ask my other question to Médecins Sans Frontières, Doctors Without Borders. In a report from
from April last,
according to Doctors Without Borders, Canada has to support the waiver to intellectual property. For a number of weeks, we've heard different perspectives, which would lead us to think, well, there's Joshua Taba, the Director General of Health and Nutrition at Global Affairs Canada, who told us recently that it's no longer a problem of supply, but rather demand. It seems that there's issues with developing countries and their acceptance of vaccines. Perhaps Mr. Ferry would like to comment on this, on Mr. Taba's comment, but we received Mr. Berkeley from Gavi, which is an organization that manages COVAX, and he said, Dr. Berkeley said that even if restrictions were lifted on patents, it wouldn't necessarily facilitate the manufacturing, the delocalization of manufacturing into developing countries, because there would be an issue of capacity, not only industrially, but also for knowledge, the know-how, as he said. So what is your response to these assessments? Whereas lifting restrictions on intellectual property wouldn't necessarily resolve the issues, because we are in another phase of the situation now.
Thank you for the question. I'll answer quickly because I think that you also wanted Mr. Ferry to jump in. But there's a couple of things. So first of all, I'll say that our position has always been that removing intellectual property barriers were one part of the solution. And I think that it has always been clear that removing the patent issue from the equation was never going to be entirely sufficient. We have always said that in addition to this, there needs to be effective technology transfer to manufacturers in low and middle income countries. I think that it is also clear that there is capacity in countries to produce vaccines if they have the legal right to do so, and if the technology is transferred to them, technology transfer and manufacturing know-how and so on. I do agree that, and we said this in our statement as well, we are in a different phase of the pandemic where supply is no longer the predominant issue. But that's a relatively recent development. And we have also always maintained that what countries needed was a stable, predictable supply of vaccines from the start. We work in roughly 70 countries around the world. We supplement and provide vaccination campaigns and activities in many low-income countries. We're familiar with the difficulties of running, even basic vaccination campaigns in difficult circumstances. Under-resourced health systems, we're always going to have a difficult time scaling up vaccination campaigns. But the solution to that was to make vaccines available equally and equitably throughout the pandemic, so that countries had the ability to scale up their vaccination activities, be able to plan for them and roll them out.
Merci beaucoup, Monsieur Bergeron.
Thank you very much, Mr. Bergeron.
Person, please, for 6 minutes.
Thank you very much. And I would also like to echo the comments by our chair to express my condolences to Vice Minister Blanco Ferrari. And I think I'd like to start with some questions for you, Vice Minister, as well. Following up on what my colleague, Mr. Bergeron, has talked about, the Canadian Access to Medicines regime is the process through which you had tried to get that licensing and tried to get the vaccines for the people in Bolivia. Can you talk a little bit about the barriers you faced? You just expand. I know you spoke about this, but I want us all very clearly to understand that this is a broken system, that CAMR was not possible for you to work through, and how we could make sure that it is fixed in future pandemics. So if you could talk about the barriers you faced, whether or not you would recommend another country go through this route, and what could be done to improve the CAMR, the Canadian Access to Medicines regime process.
Muchas gracias.
Thank you very much. We began the compulsory license process, which is part of the multilateral norm with TRIPS. TRIPS foresee this type of global crisis, this type of emergency, and so there's the compulsory license process and the voluntary license process. So Bolivia, with this pharmaceutical company based in Canada, BioLice Pharma, the first thing it did was see about the possibility of producing vaccines for us. And first, they tried to obtain a voluntary license to see if they could have the license without further bureaucracy, because we were in a global crisis. They were not able to obtain that license directly from Johnson & Johnson's, which didn't respond to them. So we went the route of compulsory licenses. That's the second mechanism in TRIPS under the World Trade Organization. This process indicates that you need to have political will from the importing and the exporting country. In the case of Bolivia, we didn't have capacity at that time to produce our own vaccines. So we had to contact this Canadian company, and as an importing country, we notified the WTO. As indicated in the requirements, we said that we had requested this, and we all know that the pandemic is a global problem and that this mechanism should apply. But the second part of the mechanism indicates that the exporting country also has to notify its intention to export under the compulsory license program. So Canada needed to include the vaccines against COVID as part of an annex to products that fall under these compulsory licenses. That's why we made the request for Canada to include in that appendix, which would have meant that BioLice Pharma would have been able to produce 15 million doses for Bolivia. We already had the price negotiated with BioLice Pharma. The only thing that we were missing was that license, so that, and it would have been Canada that would have notified the WTO that the vaccines could be exported from its country. And that's where we ran into difficulty. As I've mentioned, through press conferences, we received support from Canadians. We gathered 4,500 signatures. There was a petition in the House of Commons, but the government response went otherwise. They said they work with COVAX and that under the WTO, they will continue working with all countries, but they don't answer us whether they will export the vaccines from BioLice Pharma. So it hasn't been possible. We've been waiting for over a year for this authorization. In Bolivia, I'll echo what the Doctors Without Borders representative said. The problem with supply was last year when we didn't have direct access to vaccines. Countries like Bolivia didn't have vaccines. But for future opportunities, when this type of pandemic or emergency reoccurs, it's important to be able to modify these processes, and national standards shouldn't put bureaucratic obstacles in place.
Interrupt. I'm just going to very, very quickly. I just have a few more seconds, and I just wanted to just clarify. So it was lack of political will. BioLice was able to produce the vaccine without the tech transfer. The only barrier was on intellectual property, and I just want it to be very clear: the government failed to provide that authority. They failed to provide that political will. Is that accurate?
Así es.
Yes, that's correct. There was not enough political will for the compulsory license that would have allowed Bolivia to have 15 million doses of vaccines. BioLice Pharma was ready to produce them. We had a contract signed with them, and the only thing missing was the authorization from the Canadian government that a year later we still don't have.
So sorry, people died because of our failure.
Thank you, Ms. McPherson, and thank you, Vice Minister Blanco Ferry. Colleagues, this takes us to the end of our scheduled time with this panel. We have a second panel that's waiting to speak to us, and we also have some time set aside at the end of the meeting to discuss drafting instructions for the report on this study, which is critical in terms of the pathway towards actually releasing a report before we break. With the concurrence of the committee, I would like to thank our witnesses for panel one for being with us. Vice Minister Blanco Ferry, Dr. Nickerson, and Dr. Houston, thank you all for your time, for your expertise, and for the work that you do. And we will let you disconnect and then transition to our second panel. We'll suspend briefly.
the witnesses from the second panel. We have with us Professor Marc-André Gagnon, Associate Professor, School of Public Policy and Administration, Carleton University, as well as Dr. Madhukar Pai, Canada Research Chair in Epidemiology and Global Health, McGill University.
We will give each of our witnesses 5 minutes for opening remarks, and after that we will go into questions by members. Just for the benefit of our witnesses, I have a manual way of signaling when there's 30 seconds remaining in your questioning or testimony time. Please keep an eye on that report, on that card for the purpose of time management. We will go ahead. Professor Gagnon, je vous invite.
Professor Gagnon, 5 minutes please for your opening statement. Thank you very much. Thank you for the invitation. My statement will be on intellectual property and COVID-19 and reforming institutional structures to have quicker and more equitable manufacturing at home and abroad in times of pandemics, not only COVID-19. I have over 150 publications. I specialize in this area, and I was a witness for the Superior Court of Quebec, but I have no conflict of interest apart from that to declare. A year ago, I presented at the International Trade Committee on the suspension of trips for COVID-19.
Il a été impressionnant de voir comment les chercheurs, à l'échelle globale, ont collaboré.
It was impressive to see at the beginning of COVID how researchers shared information with regard to the genome and its evolution, and on the provision of protective equipment. The access program was based on exchange of information and know-how and technology for combating COVID, and there was also a mandate for the sharing of patents related to COVID. At the thought, there would be access to cooperation so that each country could do its best in combating the virus. And unfortunately, the patent holders and technology holders continue to insist on maximizing their own revenues and working in silos. For example, vaccine proprietors were reticent to negotiate agreements for the sharing of COVID technology, and sharing would be the most effective and fairest way of combating the pandemic. The national vaccine companies and the defense of patents has created an artificial maintenance of their interest rather than their interests of the public. And Pfizer has said that the respect for intellectual property is a human right. Patents are a mechanism for protecting research, and they can be useful, but patents exist to encourage innovations in the long term by slowing the diffusion and distribution of vaccines in the short term. The insistence on patent respect is a deterrent to the sharing of vaccines, and public subsidies, market guarantees have been essential in developing COVID vaccines and reducing risk for private researchers. And in this context, patents are superfluous. And even if governments invest billions in vaccines, we continue to find that it's normal that they are monopolized by the private sector. Maintaining patents just provides for protecting the revenues of, for example, Pfizer, which doubled. And Pfizer is predicting another 25% of increase in profits in 2022. It's not just for COVID-19. Each new pandemic, we must suspend patents and use other ways of encouraging innovation. In South Africa, reverse engineering was used to copy the Moderna vaccine. It took several more months to develop a similar vaccine to be used in South Africa. They managed this even before the Omicron wave, and the South Africa will be able to provide its own vaccines, and it will be after Omicron that vaccine will be distributed. And we talked about the waivers, but I'd just like to conclude by saying that Canada must stop being part of the problem, and it must immediately put COVID-19 on Annex 1 of the patent laws, and it must ensure that all COVID products, all patents are suspended, and the same thing must be done for any other pandemic. And Canada must also encourage the sharing of open sharing of all products to fight COVID and all health products where patents have been an obstacle to public health. I hope that Canada will be on the right side of history in the future. Unfortunately, I've been very disappointed up till now. I'm ready to answer your questions. Thank you very much. Thank you for your appearance and for your presentation.
To give the floor to Dr. Pai for opening remarks of 5 minutes. Please go ahead, sir.
Thank you very much for giving me this opportunity. I would like to make my remarks about the critical importance of self-sufficiency in vaccine production in all crises. Firstly, I want to acknowledge that last year around this time, I was very lucky to get my vaccine shot here in Montreal, and I'm extremely grateful to Canada for making that available to all of us. At the same time, India was going through a catastrophic Delta wave crisis. So I was struggling to reconcile my two worlds, where I and my family, even my child, had easy access to vaccines here, but my friends and family and brothers and sisters and everyone in India was struggling. In fact, the Delta wave ripped through an unvaccinated country. And when the dust has settled, WHO just estimated that India may have lost 4.7 million people during 2 years. I have no words to capture the devastation. I'm still traumatized by seeing so many people die. And I just can't stomach why we would allow country after country to get devastated by this virus. Letting this virus rip through the world is a very bad strategy. And 15 million lives at a minimum have been lost. And we have to do better than this. Today, India is in a much better place. Why? Because India manufactures its own vaccines. 2, it has vaccinated most Indians, at least with 2 doses. Why should every country in the world not have the same access in this catastrophic crisis we are facing? Only 16% of the population of low-income countries have had even 1 dose. And even as my province, Quebec, has just made 4th dose available, to me and anyone over the age of 18, I'm appalled that nearly 3 billion people around this world have not even had a single dose of the vaccine. This pandemic is far from over. Please do not believe anyone who's telling you to move on. We cannot move on when this virus is absolutely mutating at a very fast pace. We are already seeing subvariants cause so much damage and new waves. And long COVID is another damage that none of us have really calculated. Allowing this virus to mutate and infect more people will result in long-term consequences for all of us. We cannot vaccinate just Canada or rich countries and boost our way out of this crisis. Vaccinating the world equitably and distributing tests and antivirals is the only long-lasting solution for us as Canadians. Let us remember this, please. There is no way out of this mess if we do not equitably vaccinate the world. And yet, I am truly disappointed with what we have done so far. I know in terms of our intent, our Prime Minister has said explicitly that vaccine equity matters to us as Canadians. But in terms of our actions, we've only donated 15 million doses. What did we do with all the extra doses last year when there was so much devastation all around? Why did we not donate them and save more lives? And why have we acquired the reputation of being a vaccine hoarder globally? That's not a reputation we want as Canadians. We are better than this. And I want to say that giving money is a great thing, and I'm glad we're giving money. But I think every country is now saying charity is not what they're looking for. They're looking for justice and self-sufficiency. I cannot imagine anyone better than Dr. John Nkengasong of Africa CDC, who put it so eloquently in one of his articles. He said, never should we have had keep counting on externalities to take care of our own security needs. A key pathway for collective global security is an Africa that is self-sufficient. Self-sufficiency is something we should get as Canadians. Why? In the early days of the vaccine, we had no Canadian vaccine. We had no ability to manufacture. We were at the bottom of the list, and we were desperately looking for shipments from Moderna and Pfizer and from all parts of the world. And today, we have a Canadian vaccine. We are starting manufacturing in Montreal. We are investing in domestic manufacturing. Now, please tell me why other countries don't deserve to do the same. If we believe in vaccine self-sufficiency, why should every country in the world not aspire to have their own ability to make antivirals, tests, and vaccines? Our lack of TRIPS waiver action is disappointing to me for that reason, because the TRIPS waiver alone is not enough. But in combination with tech transfer, mRNA hubs, and other initiatives by WHO and others, it can completely change the game, not only in this pandemic, but for future crises. The best way to protect the world is to have as many countries in the world be self-sufficient in terms of their own ability to make vaccines, tests, and antivirals. So in closing, I would love for us to do three things as Canadians. Immediately and publicly back the TRIPS IP waiver, not only for vaccines, but also for tests and antivirals. We must also fund the WHO and the Africa Union to develop their own mRNA hubs and promote self-sufficiency. Vaccine self-sufficiency by other countries should be our explicit stated goal. That is what will keep us safe, not only now, but in the future. Let's please donate and honor our pledge for 200 million doses. Let's do it and put a timeline on it. Within the next 6 months, I would love to see all 200 million doses successfully donated. And let's provide more funding for vaccine delivery so that we can support ACT Accelerator and other initiatives. Lastly, even as rich countries are declaring the pandemic over and cutting back on funds for global vaccination efforts, as the White House is doing, the scientific, moral, and economic case for vaccine equity remains extraordinarily powerful. Please, Canada, let us do the right thing. Thank you.
Dr. Pai, thank you very much for your opening remarks. We'll go straight into round one, 6-minute allocations to start, and leading us off is Mr. Chung. Please go ahead.
Thank you, Mr. Chair. I'm just going to take a minute before I, through you, pass the floor over to Mr. Marty. I just want to give notice of a motion for consideration at Thursday's meeting, and I ask if you could set aside the final 10 minutes of that meeting for consideration of the motion I'm going to give notice for. That the Standing Committee on Foreign Affairs and International Development supports the full participation of Taiwan in the International Civil Aviation Organization and its 41st Triennial Assembly to be held on September 27th, 2022 to October 14th, 2022, and that this be reported to the House as soon as possible, and the committee requests a government response. So it's very similar to a notice of motion I gave some time ago, but it adds to it the clause that the committee requests a government response, which would preclude us from moving concurrence in the House for 4 months, and hopefully will allow all members of the committee to support this motion on Thursday. Thank you, Mr. Chair. That's all I wanted to do at today's meeting. Thank you.
Thank you, Mr. Chung. And am I correct that you're delegating the rest of this time to Mr. Morant? Okay. You've got about 4.5 minutes left in the allocation.
Okay. Thank you, Mr. Chair. Dr. Pai, I take your point with respect to domestic capacity, and I know that the government of Canada made a SIF grant to a company called Medicago for that purpose of $173 million. Problem is that they developed a vaccine, the Covifenz vaccine. You may be aware of this issue. But when they applied to the World Health Organization for an emergency permit, they were denied, and they were denied because Philip Morris, the tobacco company, has a major stake in Medicago, and the World Health Organization has a policy that they won't do business with tobacco companies. Do you see this as a failure of due diligence on the part of the Government of Canada and a misstep in terms of trying to not only develop domestic capacity, but to be able to meet our COVAX obligations as well?
Thank you, sir. I'm pretty sure I'm not an expert in this in tobacco, but this tobacco regulations that all UN agencies have to comply with is very old. It wasn't developed just around COVID. In other words, if anyone would have done due diligence, they should have picked up that tobacco company involvement in it would have eventually hit against a UN policy or regulation. At a minimum, just calling WHO and asking them if this were to be developed and if a tobacco company was involved, what would happen to the approval? We would have learned very quickly that it may not have been approved. So in which case, the government could have then invested the money in some other deserving company. So all I would say is we should have anticipated this.
Thank you for that important response. Dr. Gagnon, I just want to clarify, you made a comment with respect to patent holders maximizing their revenue throughout this whole COVID episode. But there's a CARE report out that says that for every $1 that donors spend on vaccine doses, they're spending roughly $5 actually delivering the vaccine. And it seems to me that those two things are equally, if not actually the delivery, the cost of delivery is actually, if not equally, even more important than the cost of donating the vaccine. Have you done any research, or do you have any concerns over why it costs so much to deliver these vaccines? Are you there?
Sorry about this. So we're talking about the cost for donating the vaccine. So basically the manufacturing cost, basically money that goes to company versus what needs to be paid for delivery. So basically bringing the vaccine to the arms of some people. The thing is, the issue of intellectual property is not based on this problem of the distribution cost, but these are important costs that needs to be taken into account in terms of when we provide donations. It's not about just shipping over some stacks of vaccines. It's about making sure that we're helping different countries to make sure they can run a vaccination campaign in a proper way. And keeping in mind that just giving away the vaccines we don't want, for example, in the case of AstraZeneca, so when we saw that there was some safety issues with the AstraZeneca, basically just saying, okay, now we're going to be just
sorry to interrupt.
giving this away. And
such limited time. I do appreciate the response, though. Just one quick question for either of you, actually. So the WHO reports that 6.24 million people have died from COVID, and I noted Dr. Pai mentioned it was more like 12 million. But The Economist had their own analysis where they showed that COVID-19 deaths are in fact far higher than officially reported numbers. And their estimate is based on that they track excess deaths over the baseline norm. I'm just wondering if you could comment on which number, in your opinion, would be more accurate. Is it the 6.24 million of the WHO or the 21.2 million that The Economist magazine has predicted?
Mr. Morantz, we're out of time on this round, but very briefly, perhaps just A or B, or if you'd like, either of the witnesses would like to submit their thoughts in writing, that's acceptable as well.
I think WHO just published an excess death report last week, and their estimate that it's closer to 15 million. than 6 million. I think everybody in the world agrees that everybody is undercounting COVID deaths. The reality is somewhere 15 plus million.
Thank you. Thank you very much. Dr. Fry, please, for 6 minutes.
Thank you very much, Chair, and I want to thank everyone for coming in. It's nice to see Marc-André Gagnon here again with us because he's such an expert on so many things. I really respect his thinking and the work that he's doing. I just wanted to ask a couple of questions. We're talking about the compromise. I wanted to talk a little bit about the compromise text and the fact that the United States, European Union, India, and South Africa are actually having trouble getting to grips with getting this compromise text done. Now, first and foremost, the whole concept was that it shouldn't just be vaccines. We talk a lot about vaccines, but I think we need to talk about testing, tracking, surveillance. Here's the idea of how do we know if it's 15 million or 6 million? If you're not testing and tracking and surveilling, then how do you know what cases you have? So that's my first question. The second one is, why are treatments being left out of this agreement? And, what about this compromise that they're talking about that fails to address the non-IP components, trade secrets, et cetera, et cetera? What can we do to move this along? What can Canada do to look at how we get this compromise agreement passed? What are the stumbling blocks? Do any of you know?
So I can jump in if you want. So this is an important question. So let's keep in mind, so the compromise text, well, it's a compromise in a way that I think is very problematic. Basically, we're just focusing on Article 31 of TRIPS, and we're putting aside Article 39, which is about non-IP, so basically trade secrets. And this is important because, especially in the last 20 years, there's been an evolution in the organization of intellectual property and patents, where more and more the patent offers very little understanding of the technology itself, and it's way more focused on trade secrets. And the thing is, if you give away the recipe without the trade secrets that goes with it, when the trade secrets have become a central part of your capacity to produce the knowledge, to produce the technology, the vaccine, basically, in the end, this compromise will not go very far. And the thing is, what's important during times of pandemics, we're talking about COVID-19, we can have a new variant emerging that is very bad and the vaccine is not working, basically, and then we will be in the same movie again. We can have a different pandemic with Ebola, for example. And the thing is, we need to prepare for a capacity of sharing, both for the know-how and technology. So this is Article 39, which is excluded from the compromise, but as well, just making sure that if there is help and technology transfer between countries, basically that will not bring a déluge de poursuites, basically a rainfall of lawsuits and litigations.
Thank you. I just wanted to ask another question. I mean, we are studying vaccine distribution, but actually the whole issue, for instance, of testing and tracking and surveillance, the issue of we've been told by some witnesses that it isn't about vaccine supply anymore. It's about how countries that get the vaccines can distribute it, can make it happen. And we're talking here about basic infrastructure. We're talking here about personnel to give vaccines. We're talking about a whole lot of things. Why aren't we focusing a lot on that and on the issue of therapeutics? Vaccines sometimes are like trying to close the door if you're trying to give vaccines now that the pandemic is on, it's like closing the door after the horses ran off. So we need to be focusing on things like therapeutics. And so what do you advise that Canada should do in looking at providing infrastructure for distribution of the vaccines within the country of origin, the country of reception? And what are we going to do about things like therapeutics? How are we going to push that forward?
Go ahead, Marc-Andre, and then I'll go after you.
Well, maybe one element I would like to bring in that for me is important. WHO has this little organization when it comes to flu, which is called the Global Influenza Surveillance and Response Network. So basically, they're taking care of seasonal flu. And the whole organization, basically, it's working with different countries. Everything is in open science. Everything is in collaboration. This is the best way to do the screening, monitoring of what's going on, the evolution of the different diseases. And this is working very well. And this is the type of infrastructure we would have needed from the start when it comes to COVID-19 and when it will come to other influenza and pandemic as well. So one great example is this Global Influenza Surveillance and Response Network at the WHO.
Well, that's about that. But what about the issue of therapeutics? I'm still focusing on that because we need to treat people faster now than trying to prevent the vaccine from spreading. I mean, it's already spread.
So when it comes to the therapeutics, so I mentioned, there's the CTAP to develop the technology, but the MPP, which is a patent pool from UNITAID, but this is a voluntary patent pool. And both Merck and Pfizer have been using this, for example, Pfizer with Paxlovid, but at the same time, they can impose the conditions. So basically, they said, we will be exchanging the technology, make the patent accessible, but only for low-income countries under specific conditions. And that's the reason why when the Dominican Republic said, well, we do want to use a compulsory license for us for this therapeutics that is Paxlovid, and Pfizer simply refused and claiming this is our human right to decide what we want to do about it, and this is nonsense.
Merci beaucoup. Merci, Dr. Fry. Merci.
Thank you very much. Thank you, Dr. Fry. Mr. Bergeron, 6 minutes, please. Thank you, Mr. Chair. Thank you to our witnesses for being with us today and for informing us through their comments. I'd like to begin, Mr. Gagnon, with a question that you've discussed before and that one of the earlier witnesses discussed before, Doctors Without Borders. So this would be subsidies that have been necessary and that were paid by Canada for nanolipid particle technology. So this was developed by universities in British Columbia. So if this is the case, if the majority of investments for the design of vaccine come from public funds, are we not paying for vaccines twice? That's something you've asked. So it's a question I've raised with the president of AstraZeneca at a meeting on April 25th, and I asked, did you give your vaccine considering the subsidies paid, and did you make the vaccine profitable once subsidies would have been repaid, in quotation marks? And I didn't get a real answer to that question. I was told that they continue to give to developing countries, but that in developed countries, there's a tariff for some profitability. What do you think of that answer provided by AstraZeneca and of the possibility that we've funded the research and development of nanolipid particles? With AstraZeneca, we're talking about AstraZeneca's vaccine. It's from the University of Oxford that was transferred to AstraZeneca under some conditions in the license. And AstraZeneca is the only company where there was technology transfer, which AstraZeneca has done, and the company committed to selling the vaccine without making any profit during the pandemic. The first time I saw a press release saying we weren't in the COVID-19 pandemic and that it was time to talk about endemicity, it was in an AstraZeneca press release, which was in a bit of a rush to say the pandemic was over. So, yes, patents aren't, it's not one company producing one technology. There are networks of companies that have worked on the same thing. So the patent network is important. And yes, a university from BC. Well, it went to Genevant, the technology, a Canadian company. The sound has cut out.
Pause.
Présenté avec quelqu'un de...
With someone from Providence Pharmaceutics, Mr. Chair. Yes. And simply, excuse me, Mr. Gagnon. I apologize for interrupting you, but we missed part of what you said after patent. We missed about 30 seconds of what you were saying. So I apologize, but could you repeat for the benefit of committee members? Please go back a little in your answer. Okay. Well, I had talked about AstraZeneca and what I was saying. With Genevant, the Canadian company that possesses a large part of vaccines for mRNA vaccines. We had Providence Therapeutics, a company from Alberta that wanted to do technology transfer for mRNA technology for vaccines. And they were blocked again and again. They weren't allowed to go forward. So it may be important. There's not just BioLease that could have manufactured. There's a company in Montreal as well, and Providence Therapeutics in Canada that are able to do technology transfers, and they were blocked by institutions from going forward.
Si vous me permettez, Monsieur le Président, j'aimerais...
If I may, Chair, I would like to carry on the same subject. We had the Vice Minister from Bolivia who was talking about the difficulties that they encountered with regard to BioLease Pharma and the Canadian access to medicines regime and the transfers of technology that would have permitted production of the vaccine in Bolivia. But I think the Canadian access to medicines regime has not been very effective because only one country up to date has made a request, since the procedure is very complicated. According to you, how can we explain that the system doesn't work? And as you've just explained, we can see that Canadian institutions have been organizing themselves so that it will not work. For me, I think it's a regime that the regime was organized in partnership with the pharmaceutical firms who have put in place bureaucratic obstacles to make this process complicated. In 2011, Canada, in fact, adopted a law to reform the regime, and a majority of Parliament voted in favor of the reform to reduce these bureaucratic obstacles. But then there was a election campaign, and so the law was never ratified. But it's clear that this Canadian regime does not work. And I'd like to add insult to injury. In the middle of COVID-19, Canada was refusing to modify Annex 1 of the patent law to improve access to COVID technology, to ensure access to technology if any country decided to persevere in getting authorization, and Canada refused to change the situation for the assuring of technology. Thank you very much, Mr. Biron. Now,
Thank you, Mr. Chair. Thank you very much to our witnesses for being here today. This is such important testimony. It is my 50th birthday today, so this is a perfect birthday present for me. Actually, thank you so much. I'm going to start with Dr. Pai, if I could. I read an article that you wrote last week, Dr. Pai, and actually I'll submit it to the analysts so that they can have a look at it as well. But you talked about how ensuring that vaccine equity, global vaccine equity happens is the most selfish thing we can do. That in fact, it is the thing that will protect us the most. It protects us both health-wise from future pandemics, but it also protects us. And, if you can't do it because it saves lives, can we not do it because it's good for our own health, but also good for our economy? Could you speak to that a little bit more? I'd just like to give you some opportunity. And one other quick thing before I stop is I know that you didn't have a chance to respond to some of the previous questions, so please take some time to respond to that too.
Thank you, ma'am, and happy birthday again. So yes, I did a whole segment for CTV News along with Dr. Joanne Liu and Dr. Richard Gold, which was telecast last week, where I said the most selfish thing that we could do is help vaccinate the world. And the rationale is very simple. We are already in the third year of this pandemic because this virus is running unchecked. Reducing the overall transmission of the virus is the surest way to reduce the number of mutations and bad variants. And bad variants are absolutely coming our way, which is what I wanted to mention to Dr. Fry as well. It is never too late to vaccinate because we don't know what bad variant is coming our way. Sure. Already we are seeing that the subvariants are even more transmissible, every single subvariant. And all it takes is another mutation perhaps to make it as deadly as the Delta variant, then we would be in an all-out crisis all over again. And I don't think we can deal with that. Secondly, we're not just talking about transmission. The long COVID consequences are terrible, disastrous for the whole world. So there is a very good reason to vaccinate, even to prevent long COVID and the complications. Now, in terms of the selfishness, I cannot do better than Joseph Stiglitz, the Nobel Prize economist. He just published an article last week in the journal that I edit, and the title is "Vaccinating the World is a No-Brainer from an Economic Investment." The Economist magazine called it the deal of the century, with an economic return in the order of several thousand folds. In other words, there is no better investment anybody can come up with than vaccinating the world, which is why the G7, including us, should have done this more than a year ago. We could have put down 50 billion or whatever is required to vaccinate the world, and by now we could have saved multiples of trillions. That's the difference between billions, pay now, be done with it, or continue this pandemic into year 4, deal with all the consequences, deaths, 15 plus million, long COVID, economic damage, and already Economist magazine and IMF estimate that trillions of economic losses have happened. So it is foolish to hold on to anything that will prevent this virus from multiplying. And stockpiling vaccines, not supporting domestic manufacturing is absolutely foolish because we will be paying for it in the coming years. So I would rather that we pay now and pay less rather than hoard vaccines, not do the right thing, and suffer with millions of trillions of dollars of economic losses. And our borders are open, no matter how hard we try. New variants are going to keep coming in. We saw it. Every single variant came from somewhere else and devastated our health system. Can we afford a Sigma variant? Are we ready to go into another lockdown? We are not. So that's why I'm saying the most selfish thing we could ever imagine is to helping vaccinate the world and share the therapeutics. And ma'am, you're right. Antivirals are absolutely critical as well. And there was a beautiful article in the New York Times saying Paxlovid is pretty much not going to be available for low and middle income countries.
Okay,
why
thank you.
Richest nations gobble all the supplies? Same thing, if there's a new variant of the vaccine available, Omicron vaccine, again, high income countries will take everything. Low income countries will be bottom of the pile. That is why their self-sufficiency gives them a chance to modify their vaccine as and when they need to.
Thank you, Dr. Pai. And I'm going to ask this one question for both of you, because I think it's something we really do need to get on the record. Do you feel that the response we've seen globally, particularly from the Canadian government, do you feel that there is any likelihood that if there was a new pandemic, a new variant, an expansion, that a different result would happen? You know, the result when you look at CAMR, when you look at COVAX, when you look at our vaccine response. Dr. Pai, I'll start with you, but if you wouldn't mind saving some time for Dr. Gagnon as well.
The answer is a resounding no. The selfishness, greed, and myopia of the richest countries in the world that we have seen the naked display of in the last 2 years, I'm 100% convinced the next crisis we will behave the exact same way. We will go nationalist, we will go isolationist, we will only look inwards, we will not even look beyond our boundaries, and we'll be back in the same crisis all over again. Things like climate crisis and pandemics cannot be solved with this nationalist way of thinking.
Thank you. Dr. Gagnon?
A resounding no as well, but the difference is that next time we will have no excuse for taking these choices.
Thank you.
Ms. McPherson, thank you. Thank you very much. Colleagues, we have about 15 minutes left until 12:40, at which point we're scheduled to go briefly into camera to talk about drafting instructions. With your concurrence, I would suggest 3 and 1.5 minute rounds that should complete a second round, but with pithy, shorter questions. If that's amenable, then we will go ahead with Mr. Genuis, please, for 3 minutes. Mr. Morans?
I'll take that on.
Mr. Abeltaif? Okay, please go ahead.
Well, thank you, Chair. Dr. Pai, on the Medicago, where Canadian government invested $173 million to produce a Covivance vaccine in order to donate 200 million doses of vaccine to the world, to countries who most need it. Now, WHO denied emergency permit to do so because Philip Morris is the largest tobacco manufacturer in the world that has a big stake in the company. How do you explain that? Where is the fairness in distribution and in getting vaccines to the most needed, while WHO stand in the way? Couldn't they, provide some solutions to that in the need of vaccination?
Thank you, sir. Unfortunately, I'm not an expert in this particular issue on how tobacco company involvement is seen or not. But like I said, I do not think WHO would do this only for any one company. This is their policy, and they're probably applying it for all companies, regardless of who is involved or not. So I'm afraid I'm not able to tell you what WHO should be doing or not.
But people like yourself and others are asking also for patent to be given away, so to facilitate making vaccines available. So this is another way to do so. Why do we have double standard? Why can't you call for that too? Why this is an exception while other calls not an exception?
I'm guessing WHO and UN agencies have to walk a tight line here, because tobacco company involvement has been proven to be challenging for them for across the disease areas. So for them, I think it's not just a COVID issue, it's probably a system-wide policy to not engage with tobacco companies, and to change that would require a whole another country level discussion at the World Health Assembly.
But that's also, again, another way to stand in the way of providing vaccines to most needed. And we are in one century challenge where you have, where we have pandemics such as the one we're going through. So once in a lifetime, in a century, could the WHO made an exception on this or not?
Since I think Dr. Pai is frozen, I'll jump in. We need not underestimate what tobacco means in terms of global health crisis as well. So Robert Proctor has been discussing about the Golden Holocaust, for example, looking at the history, and a move like the one by WHO to be proactive on this was very important. So basically the agreements, so we will not basically doing business with the arms companies and tobacco companies. So this is the policy. Now we can disagree with that policy in times of sanitary emergency, but at the same time, it's just WHO would have been even more criticized if they refused to enforce their policy at that time. This is very sad, and we can blame Canada for basically funding this. At the same time, we need to understand it's just this is not the role of Philip Morris to be doing this type of research. It would have
Professor
been very
Gagnon,
easy.
I apologize. Just in the interest of time, we'll have to leave it there. Colleagues, we have lost the connection to Dr. Pai. We're working to get him back. In the meantime, Ms. Vandenbelt, please, for 3 minutes.
Thank you very much. Thank you both of you for your testimony. I hope we do get Dr. Pai back because some of my questions were specifically for him, but can you hear me properly? My apologies, I didn't put this down. So I guess I'll start with Professor Gagnon first, although some of my questions are specific to Dr. Pai. And just going back through some of the testimony, I know that Dr. Pai had mentioned Canada has only contributed 15 million of the vaccine. In fact, there's an additional 87 million that's already gone to the Global South and is in arms because of the cash equivalents, which also include the syringes, which we heard in previous testimony. But that's not my specific question. It's more about all of the other things. This is about so much more than doses. I think that when you look at, for instance, manufacturing capacity, Canada is partnering with South Africa on a COVAX manufacturing task force to look at that as a pilot project. I'd be interested in views on that. The fact that a lot of countries need assistance with regulatory processes, with procurement processes, with communication to their public. And one of the examples is $50 million in the Pan American Health Organization that Canada has provided. And what Dr. Fry mentioned about testing and treating and health systems, Canada is either first or second to the ACT Accelerator in each of those areas. So my specific question is really around this idea that somehow we haven't learned from this process, and if there's a future pandemic, we wouldn't do any better. The fact is there's almost $300 million in budget 2022, specifically additional money on top of the $2.7 billion that we've already provided, but that's specifically for health systems. We heard previous testimony that health systems are the biggest indicator of the countries that either failed or succeeded. So can you comment on the support that Canada has given in all of these other areas, more than other countries, but also the support that we are now committing to improving health systems for future pandemics? Go ahead.
And I see that Dr. Pai has come back. And in fact, I would like him to answer this question because I did not follow in terms of the help we've been providing to health system. I just want to say one thing. So when it comes in terms of COVAX and donations, for me, COVAX emerged as a response against the CTAP, the COVID-19 Technology Access Pool, who wanted to develop the technology in collaboration, sharing information, etc. And COVAX was organized first and foremost as a way to maintain the patent technology in place, respect the patent system, and then it's just, well, you pay to the manufacturer and then you deliver the drug. But it's not about creating self-sufficiency in different countries. But on the healthcare system, I will let Dr. Pai answer that.
Thank you very much, Ms. Vandenbelt. That's unfortunately that's your allotment. These are very short rounds now and a compressed second round, but maybe there's a chance in the final round that the Liberal Party has to follow up. I will now, Monsieur Bergeron, je suis désolé pour cette...
Mr. Bergeron, I'm sorry, but only 1.5 minutes, please. Thank you, Mr. Chair. I'll try to counterbalance that rather optimistic vision from the Parliamentary Secretary to the Minister of International Development. Mr. Gagnon, I'd like for you to pick up on the answer you were giving us regarding Canada's actions to short-circuit the possibility of using the Canadian Access to Medications regime for developing countries. For that short-circuiting, despite the fact that Bolivia and Biolis went through all of the steps, Canada refused to add it to Appendix 1, and it went nowhere. So that's the short-circuiting that prevented them from going forward. That being said, To me, what was deplorable was that in December 2020, Canada took a position at the WTO saying that if no one uses the Canadian Access to Medicines regime during COVID-19, it proves that we don't have to go forward with a TRIPS waiver. But that statement, I'm measuring my words, was just dishonest. I don't know who within the working group on patents for international trade decided to take that position, but it just didn't make sense. Thank you very much, Professor Gagnon. Thank you, Mr. Bergeron.
Please, 1.5 minutes.
Thank you so much, Mr. Chair. And again, thank you to our witnesses. So I'm going to ask this question of Dr. Pai, and then if we have time to Dr. Gagnon. We have a system right now, CAMR. It has been in, I think we can see very clearly, intentionally a system that does not work. We heard testimony about that earlier. We have a TRIPS waiver that the government has intentionally not made a decision on. And because they haven't made a decision, that is in effect a decision. We've seen examples of hoarding. We've seen examples of not giving the vaccines that we could. Do you feel that the Canadian government has stopped action and in effect their failure to act or their failure to make decisions is in fact a decision, is in fact an action in and of itself?
I mean, how can it not be in a global crisis? Every month is millions of people affected in this crisis. During just that, I'll just give you India as an example again. In just 3 months, April, May, and June of last year, 2.7 million Indians died. Almost 1 million deaths a month. That is how devastating this virus can be. And every year we fail to act is adding more and more deaths and economic losses. So to me, time is of essence. By just sitting on this for years and years, the fact that we're even doing a study on vaccine equity in the 3rd year is so disappointing to me in and of itself. Yeah. What is there to study? We got to act because lives are at stake and our own security is at stake. Canada will pay for this. I'm sorry. We will be suffering for many, many months to come if we don't act purely out of selfishness. If you don't want to do the right thing for altruistic reason, fine. Let's do it for pure, selfish, internal-looking reasons. Let's do the right thing.
I apologize. We'll have to leave it there. Thank you very much, Ms. McPherson. Mr. Abeltaif, please, for 3 minutes.
Dr. Pai and Dr. Gagnon, I'll go back to the obstacles in providing the vaccine and getting this whole process going from A to Z without any interruption. So if you to list in priority what will the obstacles look like from the patent or passing the licensing to the delivery of the vaccination, to the infrastructures, to the resources that you have on a donor side and a recipient side, would you be able to list in priority where were the obstacles that to complete the vaccination was taking place?
To me, the biggest obstacle was the richest nation essentially cornered all of the vaccine supply last year. There was virtually nothing available for low and middle income countries, and COVAX donations was coming down to a trickle, and the world just sat by and allowed this virus to run through the whole place. And to prevent this from happening again and again and again, we need architectural changes. That is, in a crisis.
I'm interested in the whole list of priorities.
Again, you would need to give me more time than 60 seconds to give you the list. But my point is we need the structural changes and we need money and investment.
If you can summarize it.
Yes, I'm trying to. Like I said, there are structural changes that prevented low-income countries from getting supply. Now that there is supply, they are struggling to vaccinate because they don't have the resources to deliver them. I'm saying we need to fix both. They need a short supply, a predictable supply. They need to be self-reliant on their own and not depend on our charity or anybody else's charity. And they need their own delivery mechanisms that the world should be supporting.
Thank you. That's fair enough. Dr. Gagnon, can you comment on that too, please?
So the first thing would be to list at least COVID-19 treatments, vaccines under Appendix 1 of the Patent Act, support the TRIPS waiver. But what for me is very important, basically, it's just we had massive public subsidies, advanced market agreements in order to make sure that we were de-risking investment, to make sure that we move as fast as possible. We need to make sure that these alternatives to patents can be used when necessary, when basically countries get together. It's just, okay, we will be publicly massively funding this, but then we will not stick with structures where the production of scarcity is central to the profitability of some of the stakeholders.
Mr. Type, thanks very much. Our final intervention this morning goes to Mr. Sarai, please, for 3 minutes.
Thank you. My first question goes to Mr. Pai. He used India as an example of 4.5 million people dying, but India is a manufacturer and has two of the largest manufacturing facilities in the world, producing up to 160 to 190 million vaccines a month. My understanding of what I have read, that their deaths have nothing to do with the availability of vaccines, but the fact that they had one of the world's largest fairs of over 100 million people come to one place in the country and then merge back, as well as not implementing the actual vaccines that they produced and had. So how would a TRIPS waiver help a place like India when they already had 200 million doses a month being manufactured?
So firstly, you're right. There are lots of things that went wrong in India, and I've written a whole article on it in Washington Post. For sure, there were missteps, but when the Delta wave emerged in India, only 10% of India was vaccinated. So essentially, the deadly lethal strain of the virus ripped through the whole country, and that left to the carnage. And yes, India could have done many things to limit the spread of the virus. So TRIPS waiver may not help necessarily a country like India or China or Russia. That is the big BRICS countries is not what we are really worried about. We are worried about many, many other countries, especially the African continent, where after all of these decades and centuries, they do not have the ability to manufacture their own vaccines, not just for COVID. They can't even make a malaria rapid test on the continent, despite having the most malaria anywhere in the world. Having domestic manufacturing on the African continent is the best way to prepare the continent for whatever is coming next, is my plea.
That same note, I find that a little bit surprising too, because people who even had manufacturing facilities can't get the raw materials for those. So even if you get the patent or you get the formula to make it, if you can't get the raw materials, it doesn't solve the problem. And when a pandemic happens, the whole world is seeking the same ingredients. And therefore, even if they have manufacturing facilities, I don't see how they could solve that problem. You will always have concentration of manufacturing in places that can specialize in it, make millions daily, if not monthly, hundreds of millions. So the problem is a lot more complex than just giving a waiver of some sort, because when you come to things like this, you also have to have the ingredients to make it, you have to have the manufacturing ability, and you have to have the wherewithal and the will of the country to deliver those. We're noticing more of a problem is not just the vaccines availability, but actually delivering those to the arms that need them. And how do we improve those, I think, is the real issue, rather than just giving rights to manufacture those without giving the necessary ingredients and the ability to put them in people's arms.
We all agreed that this is a multifaceted problem that requires multiple intervention. TRIPS waiver is only one among them.
Yeah, so, but I'm trying
Mr. Sarai, I apologize. Okay. We'll have to leave it there. You're just a bit over your time. Colleagues, on our collective behalf, I'd like to thank Professor Gagnon and Dr. Pai for their expertise, for their appearance today, and for their testimony. Merci beaucoup. C'est fortement.
Thank you very much. It's very much appreciated.
Ask our witnesses to disconnect, and we will take a moment to resurface in camera for a discussion on drafting instructions on this report. We'll suspend it for a couple of minutes.
Merci à tous.
you.